Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. For years, teleneurology has been a tool to bring neurologic care to patients who wouldn't otherwise have access. Then, with the COVID-19 pandemic, the use of telemedicine overall has expanded exponentially, becoming in many ways a new normal in medical care. But we're beginning to see that telemedicine doesn't always bridge gaps in care. It can even contribute to health disparities. Our guest today is Dr. Lee Schwamm, C. Miller Fisher Endowed Chair in Vascular Neurology and Director of the Center for TeleHealth at Massachusetts General Hospital, Professor of Neurology at Harvard Medical School, and Vice President for Digital Patient Experience at the Mass General Brigham Health System. He was interviewed by ANA producer and vascular neurologist Amanda Jagolino-Cole, Director of the UT Teleneurology Division at McGovern Medical School at the University of Texas Health Science Center in Houston. They'll talk about the relationship between teleneurology and health disparities and where teleneurology is going. Here's Amanda.
Welcome, Lee. Thank you so much for joining us to discuss teleneurology and health disparities.
Good morning. It's great to be with you.
Let's get some definitions down. Can you describe the difference between telemedicine and telehealth, and where does teleneurology fit in here?
You know, it's a great question because a lot of these terms are used synonymously by some or meant in slightly different ways by others. In general, I think of telemedicine for most people is very specifically tied to devices, video equipment. It's the original implementation of what we now do every day over software-based video conferencing. So I think of it as very much transactional, encounter-based video consultations or visits with patients. Telehealth has more of a broader umbrella, and it includes things like remote patient monitoring or non-encounter-based machine interactions with patients, a broader swath of asynchronous as well as synchronous interactions with patients. Another term that's really emerged since the pandemic is virtual care. And virtual care, again, is kind of a bridging term that seems to encompass telehealth and maybe puts a real emphasis around the care delivery components. As far as teleneurology, I would say teleneurology can be a manifestation of any of those definitions. For most people, teleneurology was really grounded in telestroke, which was the first big telehealth application in the field of neurology to really take off. Since then, there's been a tremendous amount of progress in developing teleneurology criteria, examination skills, and really capability and competence across almost the full spectrum of neurological care.
Wow, that was an amazing overview of the different ways we use technology to manage patients. So why would you use specifically teleneurology?
So I think it's a great way to think about this by going specifically into a field like neurology. So if you had asked me, 10, 15 years ago, which is when we started this work, what fields are most amenable to a televisit format? Many of my peers would say, well, never neurology. It's too complicated. The diagnosis is such an important part, which relies heavily on the physical exam. You can never check reflexes if it's not your hand on the body. And my answer to those colleagues was always, well, when you're the attending on service, how often do you actually step in and move the resident aside to examine the reflexes yourself? Most of what you need to see, you can actually see with someone else helping you elicit the findings. And a lot of it you can do yourself. Now, there are some aspects that are still tricky to accomplish in teleneurology. And so not every visit type is suitable for video. But remember, there are so many parts of what we do that relate to coordination of care and counseling, explaining diagnoses, offering treatment options, doing shared decision-making. All of those things are appropriate for teleneurology. So why would it be as good or better to do a neurology visit over telemedicine compared to in the office? Well, a couple of things. Obvious ones like cost and convenience, right? For many patients, it's less expensive to avoid the time off from work, the travel, the parking, the hassle, the child care or the elder care, the convenience of being able to do it at times that are other than first thing in the morning when the provider's clinic might be held, but the traffic is terrible. But you also get other things like many patients come to neurology visits with family members or would benefit from having family members present. The ideal family members can't always be there because of other commitments. So the ability to have multi-party visits where disparate family members can join from different geographies into the same meeting is incredibly powerful. And then lastly, in-person visits are no longer face-to-face, they're mask to mask. In the video environment, as I'm sure you have observed yourself, Amanda, it's face-to-face with the patient. And many of my patients say, Doc, I love seeing you in person and it's wonderful, but honestly, for a regular visit, I spend an hour and a half getting to you. I spend a half an hour in the waiting room. The proportion of time I commit to the visit, you're a small part of that. In a virtual visit, 95% of the time of the visit is spent with you, and most of the time face-to-face on the computer screen. So in many ways, I prefer it. So those are just some examples, Amanda, of where I think this adds a tremendous amount of value in neurology.
It's fascinating to hear how teleneurology has expanded from its origins in telestroke. Teleneurology really helps reach patients in both inpatient, outpatient, urgent, and routine settings, and really in so many subspecialties. Are there any disadvantages to using teleneurology?
There are some patients for whom the teleconsultation environment is not helpful. It's a distraction, it's confusing. Patients with cognitive impairment may struggle just to organize their thoughts and get the experience they need in person. And adding another layer of technology on top of that may be overwhelming. So I think it's really important to always be thinking about clinical appropriateness.
So there's a fair amount of research on disparities in telemedicine, but what is most remarkable about what you do is multi-institutional research. And so I was wondering if I could ask what your multi-institutional research has demonstrated regarding disparities in patient care via telemedicine.
So we've done some different things in this field. I think the most salient message is almost any health system you look at, older patients, those with limited English proficiency, were less likely to conduct video-based telemedicine visits during the pandemic, and were the ones who were at greatest risk of health disparities. Pre-pandemic, telemedicine was a boutique offering for the willing. It was patients who chose this. Health systems weren't getting paid to do it. But then the pandemic came and two things happened. Adoption boomed in the virtual care space, but access to in-person care went almost to zero. And so we're going to need time in a post-COVID world to understand the strengths and challenges of telemedicine, because right now there's too much what I would call confounding by indication. Who you pick for a telemedicine visit, why you see them for that condition, their severity, their illness adjusted kind of risk is not randomly being assigned between telemedicine versus in-person. We have shown a couple of things. We've shown that, interestingly enough, the places where you see telemedicine adopted the most are not in rural areas where it's probably needed the most, but in fact in sort of suburban areas or ex-urban areas, which is partly a reflection of where the patients are all concentrated. But it still shows you that to eradicate disparities, you can't rely on sort of the market to do your work. You have to explicitly go after and create incentives. The other thing I want to say that was so interesting about our research was that while, again, we saw clear disparities here, as did others related to older patients and those with limited English proficiency and other social determinants of health, because Massachusetts very early on adopted a policy of reimbursement parity for audio-only virtual care, we actually saw virtual care eradicate disparity and saw greater utilization in populations of patients with limited English proficiency or social determinants of health, essentially reversing the trend because of the fact that it can reach almost anybody in almost any circumstance. And for conditions like behavioral health or substance use disorder or primary care, it can very much meet the needs of patients, especially in between in-person visits.
You mentioned about policy, and it seems that policy really has influenced how we reach our patients via telemedicine. Is there anything being done from a policy standpoint to mitigate these disparities?
Very much so. And I think, whether we can be successful as a body politic in this country and pass legislation that's necessary at the federal level, I think remains to be seen. But certainly at state level, we've seen a lot of activity. I would say I would group them into some large categories. Broadband access policies. So increasing access to broadband, making it more affordable, making it free in some circumstances for certain populations, treating it like a utility that is a protected class of access, I think will be very important. There's some communities that are doing public space conversion. So they're taking institutions like libraries and other public spaces, government buildings, and installing free broadband and also the capability to leverage those spaces for telehealth encounters, which is a really interesting thought. And then lastly, I would say coverage and payment parity, especially for audio only, so that insurance plans and Medicaid and Medicare cover this kind of care. Otherwise, it's a cliff that will suddenly result in a reduction in access again for many people.
You allude in some of your work for the need to further study telemedicine disparities. Any suggestions for budding researchers in teleneurology and healthcare equity regarding kind of solving these issues we have ahead of us?
First of all, it's a ripe field for study. There's lots of variation at the patient and provider level. So that means you need large numbers and you need a combination. I think this really calls for mixed methods evaluations, because you need to understand through qualitative interviews what the barriers are, and you need large numbers of patient encounters to see what the downstream consequences are. You really want to be able to look at cost, for example. Like, what does telehealth do for cost of care? Does it lower it? Does it raise it? Some skeptics say it just inflates cost of care and causes churn. Others say it saves, millions and millions of dollars. I just think we need more research on care models in risk-based contracts or managed care scenarios. That's a real opportunity, because there the money is sort of off the table. We've already been paid for the care. Now our goal is to deliver it in the most efficient manner possible, and that helps remove some of the distorting factors that come to play in fee-for-service medicine.
It's really interesting because we've had some form of teleneurology for decades at this point, but there really is so much left to discover about how it works and how to best reach our patients. And we really do need those metrics for the many scenarios that we use teleneurology. Are there any new technologies that we can use to better provide care for our patients?
I think there are a couple of things on the horizon that are really promising, and I think will explode in the next maybe 5 to 10 years. And I think the first one is remote patient monitoring. I think our phones capture an enormous amount of information about our behaviors, both cognitive, motor, even sensory. So many things, passive and active, that could be used to capture patient-generated health data. Smart mattresses that capture information about respiratory rate, heart rate, movement during sleep. It's what we need, that we finally have, is the cloud-based enormous computing power that's available kind of on demand in a utilization or consumption-based model that will let us take in all this data, along with extensive information about people and their behaviors that we can gather through other mechanisms and their online behavior and other traits that we know about them from claims, from pharmacy refills, and build those into a 360-degree view of the patient, facilitated by customer relationship management, CRM software systems that will, I think, potentially allow us to start understanding variations in care delivery and care outcomes. So moving away from that sort of, moving from volume to value, right? Moving away from multiple discrete encounters to more of these continuous or discontinuous embraces of patients, and using automation where appropriate to tee up recommended next best steps for providers. I think that's where the real promise of personalized medicine will be held. And I think hand in hand, we need to build out the quality frameworks that will go along with that, and that will allow us to measure the care and make sure that we're delivering on our promise, both virtually, but also, quite frankly, in person.
Well, it has truly been a pleasure to speak with you about teleneurology and where it's been and where it's going. Thank you so much for taking the time to share your perspective on teleneurology as an approach to patient care and for sharing your observations, expertise, and suggestions on how we can improve equity as a whole and individually in patient care via teleneurology.
Well, Amanda, it's been my pleasure. And to all of the listeners, I would just say, if you're doing virtual care, that's wonderful. If you've been reluctant to get involved, now is the time, learning from your peers, learning from others, learning from professional societies. So I really encourage all the listeners to get more deeply engaged in this aspect of teleneurology.
That was Lee Schwamm, vascular neurologist and director of the Center for Telehealth at Massachusetts General Hospital, interviewed by Amanda Jagolino-Cole, ANA producer and vascular neurologist at the University of Texas Health Science Center. Thanks for joining us for our show today. You can listen to past episodes of ANA Investigates at our website, myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Dr. Megan Ritchie. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.